Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 495 of our pharmacotherapy series, which majors in acute kidney injury. The next case reads SKS, a 74-year-old black man with a height of 5 feet, 9 inches, and a weight of 210 pounds, presents to the emergency department complaining of chest pain. His medical history is significant for advanced type 2 diabetes mellitus, with retinopathy, peripheral vascular disease, and advanced coronary artery disease. Based on cardiac enzymes, SKS is ruled in for STEMI. He is taken to the cardiac catheterization laboratory for a percutaneous coronary intervention. Immediately before the procedure, SKS is given iopamidol, a non-ionic, low-osmolar radiocontrast to enhance visualization of his cardiac arteries. His admission BUN is 37 mg per deciliter and serum creatinine is 1.5 mg per deciliter. 2 days later, pertinent laboratory findings include a BUN and serum creatinine of 60 and 2 mg per deciliter, respectively, and his urine output is 700 ml per day. So my first question to you reads, why did acute kidney injury develop in SKS? How is his diagnosis substantiated by his clinical findings? Radiocontrast media administration is one of the most common causes of drug-induced acute tubular necrosis. Although no set criteria exist for its diagnosis, it is generally considered after radiocontrast exposure when an increase in serum creatinine of 0.5 mg per deciliter or 25% greater than baseline occurs in 24 to 48 hours, peaks at 3 to 5 days, and returns to baseline in 1 to 3 weeks. The American College of Radiology has recommended using the AKIN criteria, requiring smaller changes in serum creatinine occurring within 48 hours after the administration of iodinated contrast media to define contrast-induced nephropathy, abbreviated as CIN, in order to standardize the varying definitions found in the literature. Contrast-induced nephropathy usually presents as a non-oliguric acute tubular necrosis, as observed in SKS, whose urine output is more than 400 ml per day. It is also differentiated from other forms of acute tubular necrosis in that the FeNA is usually less than 1%, versus the typical greater than 2%. The degree of creatinine rise and the presence of oliguria are widely variable. Because of the lack of an accepted contrast-induced nephropathy definition and differences in both clinical trial design and populations studied, estimating the true prevalence of contrast-induced nephropathy is daunting. Nevertheless, Patients without risk factors have a relatively minute risk of developing contrast-induced nephropathy. For those with recognized risk factors, prevalence may approach 50%. The mechanisms by which radiocontrast media induce acute kidney injury are complex. Initially, the radiocontrast medium produces renal vasodilation and an osmotic diuresis. This, however, is followed by intense vasoconstriction in the medullary portion of the kidney, which has been demonstrated by significant decreases in medullary PO2 after contrast administration. The ischemia is compounded by the increased medullary oxygen consumption because of the osmotic diuresis. Consequently, disequilibrium exists between oxygen supply and demand, creating ischemic acute tubular necrosis. Various vasoactive substances are suspected of decreasing medullary blood flow, including oxygen-free radicals, prostaglandins, endothelin, nitric oxide, angiotensin II, and adenosine. Endothelin and adenosine are potent vasoconstrictors that are directly released from endothelial cells on exposure to radiocontrast media. The next question reads, what risk factors did SKS have for developing contrast-induced nephropathy? Any condition that decreases renal blood flow increases the risk of nephropathy. At-risk patient populations include individuals with underlying diabetic nephropathy or estimated GFR less than 60 ml per minute per 1.72 meters squared, heart failure, or volume depletion, or those receiving aggressive diuretic regimens. Contrast volume administered during the imaging procedure as well as type of contrast remain additional risk factors. The use of the ionic high osmolar or ionic low osmolar contrast products increases the risk of nephropathy, as well as the previously discussed medications that markedly reduce renal perfusion, e.g., diuretics, non-steroidal anti-inflammatory drugs, COX-2 inhibitors, angiotensin-converting enzyme inhibitors, and angiotensin II receptor blockers. However, newer non-ionic low osmolar agents may be less nephrotoxic than older agents, but still can cause nephrotoxicity in patients at risk. Non-ionic iso-osmolar contrast appears to be better tolerated. On the basis of the published literature, gadolinium-based contrast, abbreviated as GBC, agents are less nephrotoxic than iodinated radiocontrast. However, when gadolinium-based contrast agents are used in high dosage with arterial injection in patients with advanced kidney disease, acute kidney injury can occur. More concerning is the development of debilitating nephrogenic systemic fibrosis, abbreviated as NSF, which is sometimes fatal. There is no cure for nephrogenic systemic fibrosis. Patients with acute kidney injury or chronic kidney disease with GFR less than 30 ml per minute, who have had imaging studies, e.g., magnetic resonance angiography, with gadolinium-based contrast agents are at high risk for developing nephrogenic systemic fibrosis. The U.S. Food and Drug Administration, FDA, has issued an advisory black box warning to avoid using these currently approved gadolinium-based contrast agents, such as Ablavar, Dotarum, Ovist, Magnevist, Multihance, Omniscan, Optimark, and Prohance, in acute kidney injury and stage 4 and 5 chronic kidney disease. SKS is at high risk for developing radiocontrast-induced acute tubular necrosis. He is volume depleted, as evidenced by his admission BUN to serum creatinine ratio, which is greater than 20:1. Second, it is very likely that SKS has underlying diabetic nephropathy, as evidenced by his elevated admission serum creatinine. The presence of retinopathy, coronary artery disease, and peripheral vascular disease suggest long-term uncontrolled diabetes mellitus, a risk factor for nephropathy. The next question reads, what strategies could have been performed in SKS to prevent the occurrence of contrast-induced nephropathy? Attempts have been made to minimize or prevent contrast-induced nephropathy using a variety of approaches. Decreasing contact time and the concentration of contrast media within the kidney tubule lumen may reduce its direct toxic effects. A higher urine output is associated with a lower incidence of contrast-induced nephropathy in high-risk patients. Volume expansion is a rational approach to prevent renal dysfunction in this population, because human and animal data have revealed dehydration as a major risk factor for developing contrast-induced nephropathy. Intravenous hydration with normal saline, hypertonic saline, that is 0.45% sodium chloride, and sodium bicarbonate in dextrose 5% and water have all shown benefits in preventing contrast-induced nephropathy in high-risk patients. Infusion rates usually start at 1 ml per kilogram per hour to maintain a goal urine output of 150 ml per hour. Sodium bicarbonate may be of value, but larger multi-center studies are needed to determine its true effectiveness. Notably, sodium bicarbonate may be more beneficial in decreasing the incidence of radiocontrast nephropathy relative to other fluids because it reduces oxygen-free radicals in the renal medulla and, therefore, increases the medullary pH. However, sodium overload is problematic and sodium bicarbonate should be avoided in compromised cardiac states. Data suggest normal saline should be infused at least 6 hours before and 12 hours after the imaging study to adequately reduce the risk of developing nephropathy. In contrast, sodium bicarbonate should be infused 1 hour before and 6 hours after the imaging study. The antioxidant N-acetylcysteine, abbreviated as NAC, has also been used for its renal sparing effects relative to radiocontrast media, but its role in preventing contrast-induced nephropathy remains unclear. N-acetylcysteine is believed to work by protecting renal tubule cells from apoptosis related to the reactive oxygen species. Although much data have been generated with N-acetylcysteine, many of these studies have significant pitfalls, including relatively small sample size, single-center design, heterogeneity of patient populations, differing doses, dosage forms, and schedules of N-acetylcysteine therapy, and differing hydration regimens. Therefore, trying to delineate meaningful conclusions from this body of literature is daunting. Given the safety profile and minimal cost impact as well as the significant morbidity associated with contrast-induced nephropathy in high-risk patients, its continued use is not inappropriate. At this time, recommending a specific dose of N-acetylcysteine is difficult. The commonly accepted regimens at many institutions is 600 or 1,200 mg orally twice daily the day before and the same day of the contrast procedure for a total of 4 doses along with concomitant intravenous hydration therapy. Higher doses, total of 6,000 mg over 48 hours, may be required for high-risk patients, those with chronic kidney disease or heart failure, and needs further investigation. Currently, a large randomized, double-blind, multi-center ongoing trial, the prevention of serious adverse events following angiography, abbreviated as PRESERVE, will compare the effectiveness of intravenous bicarbonate versus intravenous normal saline and oral N-acetylcysteine versus oral placebo for prevention of contrast-induced acute kidney injury. The trial will enroll 8,680 high-risk patients undergoing coronary or non-coronary angiography. Another important point is that the administration of diuretics such as mannitol and furosemide should be avoided. These diuretics result in volume depletion and increase oxygen demand in the medullary portion of the kidney when diuresis occurs, thereby counteracting the benefits of hydration. Other therapeutic modalities for the prevention of contrast-induced nephropathy have been studied. A systematic review and meta-analysis of aminophylline and theophylline have affirmed a renoprotective effect in patients who have underlying chronic kidney disease. However, large-scale clinical trials are lacking. Although the use of calcium channel blockers theoretically seems rational to prevent contrast-induced acute tubular necrosis, limited clinical data exist. HMG coenzyme reductase inhibitors have been proposed for prevention of contrast-induced nephropathy given their antioxidant and anti-inflammatory properties. However, recent studies have not shown a benefit. Limited data suggest that ascorbic acid before and after the procedure may be beneficial in preventing contrast nephropathy given its antioxidant effects. However, a recent published report comparing ascorbic acid to N-acetylcysteine showed a greater benefit of high-dose N-acetylcysteine than ascorbic acid in preventing contrast-induced nephropathy in patients at risk. High doses and long-term use of ascorbic acid should be avoided because of the risk of hyperoxaluria, oxalate-containing urinary stones, and renal damage. When possible, alternative imaging studies that do not require radiocontrast should be attempted. If this is not practical, the lowest effective dose of non-ionic low-osmolar or iso-osmolar radiocontrast media should be used. Concomitant drug therapy that can impair renal perfusion, such as diuretics, non-steroidal anti-inflammatory drugs, COX-2 inhibitors, angiotensin-converting enzyme inhibitors, and angiotensin II receptor blockers, should be discontinued 1 day before and 1 day after radiocontrast administration. Metformin is also a risk factor. It is not a nephrotoxin. However, its use has been associated with the development of acute kidney injury, systemic complications, and death in rare cases. Metformin should also be discontinued 1 day before giving radiocontrast media and held for at least 2 days after the imaging study because it may cause lactic acidosis if patients experience acute kidney injury. If patients are receiving calcium channel blockers for underlying cardiovascular disease, no change in therapy is warranted. All patients should be well hydrated with normal saline or sodium bicarbonate fluids before and after radiocontrast administration to prevent contrast-induced nephropathy. The addition of N-acetylcysteine is optional. The next question reads, what treatment options are available for established radiocontrast-induced acute tubular necrosis? Few data exist regarding treatment of existing radiocontrast-induced acute tubular necrosis. The acute management largely involves supportive care that includes strict fluid and electrolyte management to prevent undue sequelae. Approximately 25% of patients will require temporary dialysis therapy. Patients who are oliguric generally require long-term dialysis therapy. As already noted, attempts to convert oliguria to non-oliguria with furosemide and mannitol have been largely unsuccessful. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 496.